everybody. Hey, guys.
Hello, welcome.
Hi.
Hey. So we will start now. My name is Eli, and I'm the CEO and co-founder of DIA Imaging Analysis. I'd like to welcome you all to our webinar co-hosted with GE Healthcare. In this webinar, we will focus on how Handheld Ultrasound and AI support care clinicians. With us today are 4 leading physicians who are going to share their experience using Handheld Ultrasound and AI. At the end, they will be happy to answer your questions that you can add to the question box. We will not be able to answer all questions, but we will reply to all of you by email as well. Before we start, I want to say a few words about our work at DIA. DIA is a leading provider of FDA and CE marked AI-based ultrasound analysis solutions. Our vision is to leverage AI to make the use and analysis of ultrasound images smarter and accessible to all. DIA is partnered with GE Healthcare to provide a Vivo EF on their handheld device Vscan Extend, which is the first AI-based automated ejection fraction available on a handheld ultrasound. As you can see on the screen, after taking a 4-chamber view, you press 1 click, and within few seconds, you will get the ejection fraction and the diastolic and systolic volumes automatically near the bedside. So, with no further delay, let's introduce our panelists. Dr. Nelson, you can start.
Hi, my name is Bret Nelson. I am the chief of the ultrasound division in the Department of Emergency Medicine at the Icahn School of Medicine in New York City.
My name is Dr. Mike Wagner. I'm the director of internal medicine ultrasound at the University of South Carolina School of Medicine in Greenville, as well as Prisma Health Upstate.
Dr. Dadon.
Hi, my name is Dadon. I'm an internal medicine specialist and the cardiology fellow at the Jesselson Integrated Heart Center at Shaare Zedek Medical Center in Jerusalem.
I'm a professor of cardiology at Ben-Gurion University of the Negev in Beersheba, Israel. I'm a former head of the Echo Lab in Soroka Medical Center and a co-founder of DIA. And I'm happy to join you today.
Thank you, guys. So thank you for joining, and I'm very excited. And let's start our questions. So I'd like to start with the question to Dr. Wagner. Could you share with us when did you started to use Handheld Ultrasound and as well as AI, and why?
So my first experience with handheld ultrasound was during my internal medicine residency. I was fresh off of a cardiac imaging elective where my mentor, Jez Bozzato, had demystified echo for me. And then I was on a critical care elective where I met with Alex Levitov, who's an intensivist who uses point of care ultrasound as expert in the field. He actually had a handheld ultrasound at the time, Vscan, and so he saw me pushing around the line cart and said, oh, hey, I think you might find this to be useful. So I've been drawn to pocket-sized devices ever since. It really fits with the internal medicine workflow, as we tend to round on multiple floors and treat patients in different situations, different settings, in the intensive care unit, on the floor, sometimes in the outpatient setting as well. And so the availability of the technology for immediate scanning is really essential for integrating it into your practice and clinical decision-making. And so pocket ultrasound has been essential for me. When we round with the residents, we find that by adding just 2 to 5 extra minutes during rounds on some of our sicker patients, it can markedly improve the efficiency in the workup for that person's hospital stay. Regarding AI, my first exposure to AI and ultrasound was via the Vivo EF. In my view, it's very similar to the psychological benefit of having sort of an automated EKG interpretation. You formulate your own impression, but then you also have the computer to back you up. And even though in my experience, having viewed lots and lots of echoes during ultrasound fellowship, as an internist, I'm constantly sort of doubting myself and being critical of my own assessments. So it's nice to have that sort of immediate feedback and support. And I think where most other internists would find this helpful is if they're in resource poor areas or don't have a lot of colleagues to consult with. For example, when I was overseas as a junior internist, I would have loved to have had this sort of technology.
Great, thank you. Thank you for your answer. And next question would be to Dr. Liel. How did you use handheld ultrasound at the point of care for cardiac assessment? Do you think point of care physician assessing cardiac images are being accepted by you, echocardiographer?
So really on the early days of point of care ultrasound, there were voices against the use and doing echo exams by non-cardiologists. And there were real concerns about their ability to produce accurate finding by visual assessments. However, it became clear that there was a benefit to the use of point of care ultrasound at the bedside at various settings. So it was really important for immediate and accurate patient evaluation and care. Eventually, cardiac ultrasound became a routine at point of care, and we are at a great stage to have the available tools that are based on AI that can support the users and make the assessment not only visual, but really to have some tools that they can use and they can get numbers. I think it's especially important for more novice users, but it's also helpful for others so that as was mentioned before, they can have a second opinion. It gives guidance. It is a great teaching tool and helps reduce the variability between different users and the visual analysis alone. Even us at the Echo Lab, we use, and cardiologists, we use handheld ultrasound. And it's helpful for us also when we go around in the hospital, in emergency room, in ICU, etc. And even in the Echo Lab, when we have this tool on the PACS, we can use it, and it helps us when we are alone in there or when we are having a discussion and we are not sure what exactly we are seeing. The AI tool is really helpful. Thank you.
Yeah, thank you, Noah. Dr. Dadon, we have seen a growing use of AI application on users. How do you think AI-based solution on handheld ultrasound devices could make a difference for novice users?
So AI and solutions similar to Elvivo AF can come in to empower clinicians with information that's both objective and accurate so that you can really put on the benefits of ultrasound to use. As it relates to novice users, I want to share with you a recent study we've conducted. In this prospective study, we've recruited medical students that were asked to visually assess the ejection fraction and record it, and also acquire the clips. We analyzed the clips using the Elvivo EF, and within 24 hours, the patients underwent an official echocardiography examination that was set to be the gold standard. And you can see here the preliminary results that were also presented in the last ACC virtual conference. As can be seen on the upper left figure, when comparing between the students' visual analysis to the gold standard, the correlation was moderate at most. However, comparing the Elvivo EF to the gold standard, you can see on the upper right, the correlation was substantially increased. As can be seen on the lower figures, when we chose a cutoff of 45% as the ejection fraction, Elvivo EF enabled medical students to achieve near perfect results of agreement between their evaluation, the Elvivo EF evaluation, and the expert echocardiographers. Now, this study was conducted in the pre-COVID-19 era. I believe that it is even more relevant now in the COVID-19 pandemic settings, taking into account the COVID-19 protocols and precautions.
Yeah, definitely relevant and very impressive. Speaking about COVID-19, clearly the world and healthcare has changed dramatically. during the past months. Dr. Nelson, how do you think COVID-19 has changed the use of handheld ultrasound and AI?
Well, we certainly saw many patients with COVID-19 during March, April, and afterwards when New York was the center of the pandemic. And I noticed a few things about COVID-19 changing the use of ultrasound. First was we were there were so many patients that we were dealing with that we were for the first time really dealing with a situation of limited resources, limited staff, limited availability of X-ray and CT scan, and that limited resources played itself out in several different ways. First of all, handheld ultrasound was much easier to use than cart-based machines. It was easier to bring to the patient's bedside, especially among practitioners that were going to be at the bedside anyway. So imagine the workflow difference when you are the practitioner that's caring for a patient and you already gown up and glove up and put your mask and your shield and take all the appropriate PPE precautions, and you go to the patient's bedside. While you're there, using handheld ultrasound and assessing their heart and their lungs is very efficient for their workup. It also means that someone else doesn't have to expose themselves to that patient with a portable X-ray machine or bringing the patient over to the CT scan or radiology suite, which then has to be cleaned afterwards, reducing the turnaround time and reducing the use for other patients. It's much easier to clean a handheld device than it would be to clean a device that needs to be a cart-based or a stationary device. So the other thing is COVID was a great pilot in terms of increasing awareness how AI can assist with diagnosis. There were many new users of ultrasound as we saw our floors become intensive care units. We had many more providers that weren't normally taking care of critically ill patients begin to take care of critically ill patients. So people who didn't already have point of care ultrasound built into their practice, we're starting to very rapidly figure out how to build that into their practice as they learn from each other and they learn from their colleagues who were more specialized in intensive care medicine. So when you have all these novice users using ultrasound and trying to get up to speed very rapidly, the use of artificial intelligence for helping them assess things the way Elvivo does to assess for ejection fraction is very helpful. As Dr. Dadon's data mentioned, you can get people up to speed very much more quickly and have some added confidence when you introduce the concept of artificial intelligence augmenting the examination that they're already doing. Another thing we noticed was that, especially as it applies to cardiac ultrasound, we were expecting patients with respiratory illness. It took some time for the medical community, I think, around the world to realize the extent of cardiac illness, especially in the sicker patients, and recognizing that more quickly is very helpful for triaging patients to the appropriate level of care and recognizing that they have multi-system organs affected. So being able to assess cardiac contractility, ejection fraction rapidly is really important, and there have been guidelines by some national and international organizations that performing a limited echo exam on COVID patients is something that really should be done rapidly to triage them, should be done on an ongoing basis to monitor their progress. So an AI-driven tool like Elvivo is going to really improve the ability for people to rapidly triage and evaluate patients. So, so I think that the assessment of the ejection fraction is a great example of something that can make handheld ultrasound more useful, perhaps even as useful as cart-based or more complicated ultrasound machines. It can also bring new users up to speed much more rapidly and allows the use of a technology that's more efficient and rapid for assessment of patients, but also probably safer in terms of infection control.
Yeah. Sounds like COVID-19 actually accelerated the adoption that started even before. And that's what we also are seeing these days, an increased use of Elvivo EF at the point of care, monitoring COVID-19 patients' heart, as you just mentioned about the need and understanding that the virus attacks the heart as much as it attacks the lungs. Dr. Dadon, you had some interesting case studies using Elvivo EF on the VScan Extend with COVID patient. Could you get us through this case that we are now seeing on the screen?
Right, so briefly, this was a case of a 66-year-old COVID-19 diagnosed male patient who was presented to our ED with complaints of atypical chest pain and palpitations. His ECG revealed non-specific changes, including T-wave inversions, and the patient was evaluated using the VScan Extend and the Vivo EF. As you can see here in the clip, basically the examination demonstrated immediate results of normal ejection fraction and normal function of the left ventricle. So the results supported the ED physician's conclusion that myocardial infarction or ischemia can probably be ruled out, and significant virus-associated myocardial injury was an unlikely option.
Yeah, great example, thanks. Dr. Wagner, you mentioned at the beginning that you started to use ultrasound, handheld ultrasound as a resident. Do you think that the acceptance of handheld ultrasound and AI changed since, and today point of care users trust AI more?
Yeah, for sure. The pace of implementation, at least on internal medicine side, has increased. Although point of care ultrasound for some internal medicine communities in some countries has been mainstream for a while, the acceptance in the US has been historically quite low. But in my view, in the last 5 years, that's dramatically picked up. And I think that handheld ultrasound and the convenience it offers, as well as the image quality on some of the newer devices, has had a lot to do with that. Regarding AI, I think physicians, particularly specialists, often respond better to numbers and measurements. And so from the perspective of a generalist interacting with specialists who are using pocket ultrasound devices, AI could really decrease the perception that ultrasound exams, particularly point-of-care ultrasound exams, are highly subjective. Clinicians who are using ultrasound, particularly generalists and primary care doctors, are very eager for AI tools to expand and take off, to give those sort of objective measurements. And I think as the number of applications expand and increase in number, particularly for applications that are less technically challenging to acquire and are geared towards novice users, I think you'll really see an explosion of use with ultrasound. So with COVID hitting and it becoming kind of a flashpoint for handheld ultrasounds for physicians, I think it makes sense to invest in pocket-sized devices moving forward.
Yeah, definitely. You mentioned numbers and measurements, and this is something that we are also getting a response from physicians that likes to see numbers and measurements as part of their workflow. Dr. Liel, what do you think? Do echocardiographers AI today more?
So I can tell you from my personal experience using DIA's AI solutions that at first I was skeptical, but the more I used it in my workflow, the more I trusted it and encouraged others in the lab, such as fellows and other echocardiographers, to use it as well. I would like to share with you that the aim to invent a tool for automatically measuring LV ejection fraction started at my echo lab in Soroka Medical Center when Michal Yacobi, then studying for her master's degree in electrical engineering, and now the CTO of DIA, approached me willing to do her thesis on this subject. The need for such a tool, for a totally automated tool to measure ejection fraction, was clear and became even more pronounced once point of care came into the game and non-cardiologist users were aiming to evaluate LV function by ultrasound, and it was not easy for them to do it using just eyeballing. So that really there is a growing interest by cardiologists and echocardiographers to use point of care also. And if they could have assistance by AI tools that provide numbers that later can be discussed over the phone, it helps a lot and accelerates the adaptation. Echocardiographers often work alone, and having AI is a great supporting decision tool for them to have with them. and that can assist them. There is also accelerated adaptation of this tool into the workflow, and it's really convenient to work with it. Also on a PACS or on the vScan, both are really convenient and help and are quick. I personally trust that AI solutions can provide similar results to what I see. And once I see it, I really, and I see reproducible results, I really feel that it is a good solution and it should be adapted for use for really everyone that is trying to assess ejection fraction. Thank you.
Thank you, Noah. Here is a question that we hear quite often that I would like to address to Dr. Nelson. Should AI be applied on any ultrasound image? And can AI overcome the concept, as all of you know about it, garbage in and garbage out?
So, I think applying the AI to the image is very helpful. There's from what I've seen of how the LVO EF system works is when the anatomy is not appropriate to get an AI image, you'll get an error message. So, and when it is, then you can. And this is helpful in a couple of different ways. There's imaging that's not correct because the anatomy is not visualized well, or the user isn't imaging through the plane appropriately. And here's a good example of an image that a human user shouldn't be using to try to calculate an ejection fraction, and the AI knows, so to speak, to not calculate an ejection fraction on that as well, and you get an error message. And right there, that's useful for a novice user to see that the image is not the image that's ideal. That's sort of like having a consultant over your shoulder helping you out as you're scanning your patients in real time to make sure that the image is an appropriate image for further analysis. And that helps to build a pattern recognition for novice users that are ramping up their skills pretty rapidly to be able to assess this is an image that's appropriate for assessment versus not. And that's a really critical skill. The next way that the AI can help is when you have images that are maybe not textbook perfect images, but maybe an experienced echocardiographer, sonographer, clinician could look at them and make some assessments. And we see here some examples where maybe the endocardium isn't fully visible, or the apical wall isn't 100% clear, or there's an image to the right that's maybe a little bit more noisy, and the AI is able to still recognize the patterns through motion and create an assessment and put a number on it. And that's really helpful to not only look at a tool that can create an assessment and be reproducible and generalizable, as some of the previous data has shown, but also to put a number on it, because that's not only helpful in creating a common language among different users of ultrasound, so that if Dr. Liel and I, for example, are speaking about a patient, we can have some reference point to what we mean by a good ejection fraction and not be so subjective. And also during the learning phase, it's really critically important that you quantify things as you're learning. And there's no difference in starting a new workout program or trying to learn vocabulary words versus trying to learn procedural skills. The more quantitative you can be about your progress, and the more rapid the feedback loop that you can create for yourself, whether it's proper form, or knowing if you got the vocabulary words right or not, or knowing whether your assessment matched the assessment of the AI here, creating that rapid feedback loop has been demonstrated time and time again in adult learners to create a more robust learning curve. So this information is really critical. It'll help overcome inter-reader reliability issues by putting a number on it. It also helps communicate findings between people of the same specialty or different specialty, and it helps novice users, again, improve their skills more rapidly. So I think all these things are really helpful, and it helps overcome that concept of garbage in, garbage out, especially when it can recognize I don't like to call anybody's images garbage, but if it helps recognize suboptimal images and helps you improve those and optimize those for patients, that's a huge win.
Yeah, definitely. And this is, part of our work to identify that and be able to see when it's a real garbage that we should not touch, you can say, and when we can overcome the eye, the visual estimation, and give you some input that the AI can see. Thank you for that. Let's talk a little bit about changing patient treatment using AI. Dr. Dadon, at the last ICI meeting, you presented a case that shows that if AI was applied, it may have changed the patient treatment. Can you tell us about this case? We will see it in a minute on the screen.
Right, so this was a case of a 79-year-old female patient who was admitted to our ED with complaints of cough, fever, and fluid overload. The patient was diagnosed with pneumonia, and as part of evaluation, she underwent a point-of-care echocardiography, which assessed her LV function to be significantly reduced. Subsequently, treatment with IV antibiotics and diuretics was begun. Within hours, the patient developed shock, and I was urgently called to reassess the patient and perform an official echo examination. You can see here the clips I acquired, and as you can see on the left, her LV function was normal, with normal size. However, when I assessed her right ventricle on the right, her right ventricle was dilated with reduced function. The patient did not suffer from LV dysfunction, but from pulmonary embolism. And upon fluid resuscitation, the patient recovered rapidly. Now, this is not a rare case. Mistakes like this happen on a frequent basis, and had AI been utilized, this mistake and shock may have been prevented.
Yeah, this is a very good example of how AI can change care. I would like also to add that as part of our toolbox, DIA recently received an FDA and CE marked approval for El Vivo right ventricle, El Vivo RV, that automates the right ventricle size and function. So in this case specifically, if that both tools, El Vivo EF as well as El Vivo RV, would have applied, probably we could have helped change the treatment and make probably a better decision. I must say that the Vivo RV is not available yet on the scan extent, but yeah, this is exactly where we are heading to be able to help in those kind of cases. And here's a question to Dr. Liel as an echocardiographer. How did a point-of-care ultrasound and AI tool change the everyday work between point-of-care physicians and echocardiographers?
Thank you, Ila. This was really a turning point. At first, point-of-care users were hesitant, and it was difficult for them to eyeball LV function and to communicate to us cardiologists or echocardiographers what they've seen and what they think. But since AI-driven tools became available and show the LV border tracking and quantifying the LV ejection fraction, things really changed. The users and the consultant cardiologists build a trust in between them and feel that they have a more common language. As point-of-care users started using AI tools, we felt they understood what they were seeing. So it was kind of also a teaching tool, and we could talk on more common grounds. We both felt more reassured. Thus, consultation and discussion were taken more quickly and were more reassuring that really we are talking about the same thing. So I think AI helped to gain trust among echocardiographers and point-of-care clinicians, and it really made a change in the way we work together. Dr. Dadon, how do you see it as a cardiologist that is called to the emergency department or ICU for helping them out?
So in the past, cardiac emergencies such as cardiac tamponade or cardiogenic shock sometimes took more than an hour to properly be diagnosed. And now, as point-of-care echocardiography has been part of the evaluation of novice user also, it mostly takes minutes to evaluate patients who was just diagnosed. So AI may help novice users to alert problems much earlier.
Yeah.
Right.
This definitely makes sense. Thank you. And our last question for today, before taking questions from the audience, will be about the future. How do you visualize the use of AI and handheld ultrasound in the next few years? Dr. Nelson, you can start. We can hear you.
Yeah, I think once you start using AI, it's hard to go back. Everyone will probably incorporate it a bit differently, and everyone's going to incorporate it in different ways as they grow through their careers. So the novice users can use this as a way to have additional quantification and additional assistance as they build up their working knowledge and their pattern recognition for examination time after time. It's like having a virtual coach with you as you learn and grow, and then intermittently you recalibrate with other experts and other studies, and that's a huge part of the learning curve. I think it also helps to have a common language among clinicians from the same specialty and different specialties as they communicate findings with each other. So as Dr. Wagner mentioned earlier, you know, there's other examples where automated systems have at first met with reluctance, and then people start to not only get used to them, but rely upon them. I think that will happen with AI as well. And I think like those other systems, we'll rely on it not to replace our own clinical knowledge and our clinical judgment, but to augment them. So we'll be able to do you know, better triage more rapidly, be able to do multi-organ system assessments with more accuracy with patients, and hopefully there'll be more trust in the findings and more standardization across the different specialties.
Yep. How about you, Dr. Wagner? How do you vision this?
Yeah, I agree. I mean, I think that at this point, the highest value currently with AI and ultrasound is when you form your own clinical judgment first and you commit to it mentally, and then you sort of switch on the AI, right? And in this way, the value is providing in that immediate feedback to train your eye and improve your own personal skill set. And then you have a lot of clinicians, I think, you know, we're clinicians, we don't like to admit when we're wrong, and we don't like being wrong. And I think we're more often wrong than we would like to think. And this extra feature of point of care ultrasound devices, I like to make the analogy of airline takeoff and landing systems and autopilots. So when you have the initiation of autopilot, it's the primary function is the autopilot's there for backup and the pilots are there for primary. And now over time with acceptance, you have the autopilots being primarily on board, and then you have the pilots there in case the system goes wrong. And I think with AI and ultrasound, that's sort of where the future will lead us. Right now it's the backup, but in the future it'll probably be sort of the primary. And I think with the rapid increase in acceptance of pocket ultrasound devices, I think while the clinician's examination has been slow to evolve in the past century, I think this will cause a major shift on the horizon as far as how doctors examine patients.
Yep. I can tell you the vision that we are seeing in DIA. We definitely believe that in the future, several years from now, you will use those handheld devices as, you know, the next stethoscope, as everybody's saying. But then wherever you will put the transducer, you will get feedback from an AI solution. And this is where we are heading, to continue developing those AI solutions in various anatomic areas and understand ahead of time where is the need, where you guys need those AI solutions as part of the workflow. And not, you know, adding more time and more efforts, but to actually integrate fluently as part of your everyday work. So yeah, that's the main target. Now let's look a little bit about for the questions from the audience. Again, I'm sorry we will not be able to answer all questions. There is a question that I see here, and I see it all the time in webinars, and say, how do we verify that our AI is accurate? So of course that the first thing is to have a huge database, which we have, and doing the validations that the FDA asks us to do, and even you guys want to see. But ultimately, the main goal is to build an AI-based applications that mimic the way an expert physicians see those images, interpret those images, and overcome barriers that the eye cannot detect. Of course, big database and accurate reference is mandatory, but most important from our end is to make sure that our engineers and data scientists understand the clinical aspect of the development application. They must understand how the data is being acquired, how you guys are interpreting those this information, and even in a level that they can eventually interpret the data by themselves. So this is how we make sure that mentioning garbage in, garbage out, that eventually we will handle this information and help you guys get very accurate results. Another question, let's see.
I think just, I can't recall whether or not this was mentioned yet, but I do think a huge component of that will be transparency in terms of how the solution takes the measurement, right? And so rather than just spit out the number, you have kind of the visual feedback of here's where it's placing the monitors along the endocardium. This is how the measurement is coming about, and whether it's, you know, the heart or the lung or the IVC or the bladder or any other application, if the user experience can be that they see exactly how the computer is drawing its conclusions, I think that'll help to engender a lot of trust in the system. If it's just a blind, you know, behind the curtain type calculation, I think there'll be still a little bit of doubt and mistrust, so transparency will be key.
Yeah, and that's really one of the questions that we saw here, that asking why not just giving a number, and why we need to see the tracking. So yeah, that's exactly that. Noah, you wanted to add something?
Yeah, that really from the start of developing the applications, we insisted on showing the tracing. What does the machine learning or AI or whatever way we used is really seeing, and what is it tracing? And I think it really adds a lot to the feeling of the physician that gets the result, that it is true, that he sees what it's tracing and it's a real result for this patient.
If I can add, I think that that you've both spoken very well about the trust and the confidence in the use. I think it also feeds into the feedback for the novice users, understanding how to assess ejection fraction, and by seeing how the AI is doing it, and the AI is doing it, you know, not on its own, but with the feedback of countless, you know, experts and over multiple iterations, right? So visualizing how this expert trained AI assesses the boundaries and then therefore calculates the ejection fraction gives that real-time feedback loop to novice users and really accelerates their learning curve.
Yeah, definitely, and this is why we kept the tracking, which, you know, there was some dilemma at the beginning when we started, but definitely the feedback that we got is we must see why you think the numbers are as you presented, and as Noah and you guys mentioned, when you see the tracking is right, and then you trust it more. And that goes to the next question that talk about specifically about the VScan. There is the ability to manually adjust the tracking borders. And so I must say that in the case of VScan Extend, because of the screen is very small, we decided together with GE that it's better to take another image if you don't agree with the borders than to try it in a very small screen to change the borders. I think, Dr. Dadon, I know that you use it a lot. How do you feel about that? We can't hear you. You're on mute, I think.
Sorry.
Yeah.
So I think that to us cardiologists, it is important to have the option to manually edit the tracking borders if needed, because we're more trained in exact evaluation of the ventricular function. Nonetheless, as related to novice users, it may cause confusion. And if there's any doubt regarding the results, my advice is to reactivate the tool with a newly acquired clip.
Definitely.
I can add something also.
Yeah, go ahead.
It's from my own experience and use of this technology. I did correct a lot in the beginning, but then I saw that it makes such a small difference that it's not really important, and I almost stopped doing it only when I feel it may be important, or I think the tracing is not exact. But even then, usually it doesn't make an important clinical difference.
You both brought up another interesting facet of this, which is we're talking about artificial intelligence in handheld devices. And while people like handheld devices for a whole variety of reasons that we probably don't need to go into, one of the drawbacks that people often find is they don't have the same bells and whistles as a cart-based or a standard, refrigerator-sized machine. And the artificial intelligence allows basically a simpler user interface. So with the click of a button or two that you can do with your thumb, you're getting an ejection fraction, whereas to do the same process on a cart-based machine is very much more complicated. So even just as a different sort of emergent property of using the artificial intelligence, you can take a lot of the functionality of a much more expensive, larger, more difficult to learn machine and put it in the palm of your hand. And as you guys mentioned, most of the time it's the number that you're looking for. And if there is some specific example based on your expertise or that particular patient where you do want to adjust it, then there's ways to adjust that as well. So it's kind of like adding a trackball and a keyboard and a stand and a monitor onto something that just fits in your hand through the auspices of the AI itself.
Yeah, that's right. Yeah,
So
definitely.
embrace pocket ultrasound lifestyle, not refrigerator ultrasound lifestyle.
Yeah, I saw you laugh from that example. Yeah, but everything now is small and automated. So yeah, this is where we're heading in every aspect of our life. If I can summarize a little bit about what we heard today, and we heard that the use of the handheld ultrasound and AI expanded to new users, including novice users, that during COVID-19 actually changed and accelerated the adoption of handheld ultrasound and AI among point-of-care clinicians. We also mentioned that AI will not replace you guys, but it's becoming another essential instrument in your toolbox to provide you with valuable information. Having said that, I want to thank you, Dr. Liel, Dr. Nelson, Dr. Wagner, and Dr. Dadon, and thank you to GE for co-hosting this event with us. Contact us if you want to hear more about our work, and of course, if you want to contact our panelists, I will be happy to make the introduction. Thank you all, and see you next time.
Thank you very much.
Thank you.
Bye-bye.
Thank you, colleagues.
Thanks.